This video is for you if you're someone that has tension type headache, often called tension headache, sometimes called stress headache incorrectly, which I'll talk about in the video, talk about why they're not just about stress. Tension type headaches have got lots of different potential factors to them. Stress can be a trigger, but they're not a purely psychological phenomenon. It's not just down to your stress. So let's dive in. Tension headache is a common name given to the condition that's correctly known as tension type headache. There's a subtle difference in the name, but the difference is important, as I'll explain as we go along. They can be mild, but they can also range right up to severe and debilitating. And while some people may find that they can self-manage quite easily with a milder version of a tension type headache, there are many people that are down the more severe end of the spectrum that do not find it easy to manage, and it really gets in the way of their life. Another problem with the term tension headache is that it often gets swapped out and interchanged with stress headache, and stress headache is incorrect. Unfortunately, the tension type headache sufferer can feel blamed, can feel like it is somehow their fault if they're given the advice, what you need to do is manage your stress better. And in reality, there's usually a lot more to it than just stress management. And if someone is told that that is a solution, but in trying to help their stress, it's not solving their tension type headaches, then what do you conclude? It's my fault. I'm not doing it well enough. And that's not to say that stress isn't a common trigger, because it is. Stress is certainly part of the puzzle for most headache types, tension type headaches included, but it's certainly not the whole story. So I'm going to talk about tension type headaches in terms of the traditional medical model and in terms of the more modern, updated understanding about tension type headaches. And at the end, I'll talk about how we help people at Adelaide West Physio and Headache Clinic to help their tension type headaches too. The real take-home messages from this video are tension headaches are not simply stress headaches. Many factors can contribute, but the upper neck is often underestimated in tension type headache. Sensitization of the brainstem is a key component of tension type headache. The Watson headache approach is the only system that looks at the upper neck contribution to this sensitization process. Tension type headaches are really common. So the estimate is somewhere around 78-80% of people will experience this kind of headache in their lifetime. So it is common. There's a good chance you'll experience it in your life as well. What people will describe with tension type headache is a sensation of tightness or tension around the forehead, the head, usually bilateral, temples, eyes, back of the head, sometimes in a cap-like distribution. And it's described as a dull, aching pain, a pressure pain. And that's where the name tension type headache comes in. So if you think about that, how do you interpret the term tension headache? Some people interpret it to mean tension as in stress. But the actual intent behind the word tension is the sensation of tension. And that's why the name presumably got changed from tension headache to tension type headache to try and make that distinction. In the definition of tension type headaches in the International Classification of Headache Disorders, 3rd edition, they talk about tension type headache being mild to moderate in intensity. We know clinically from people that we see that it can be much more than mild to moderate. It can be severe. So I don't buy that part of the definition. I think tension type headache can extend right up to the severe end of the spectrum and quite debilitating and really interfere with life. Tension type headaches are usually divided into two types, and the distinction is often given in headaches of episodic versus chronic. Episodic headache is less than 15 days of the month. Chronic headache is more than 15 days or more of the month. So note here that the definition of chronic is used quite differently to the definition that's used in any other part of health. Chronic usually means some kind of time frame. In this instance, with headaches and migraines, chronic refers to how frequent it is. So that's a real shift in thinking. You have to be careful about that when you're looking at headache literature, what chronic means. Chronic doesn't mean it's been there for 10 years. Chronic means it's been happening for more than 15 days of a month. And according to that ICHD-3 classification, Tension type headaches are described as a primary headache, where the headache is the problem in and of itself, as opposed to a secondary headache where the headache is a result of something, a result of a condition, a result of some other kind of factor. In years gone by, tension type headache was thought to be mainly a psychological phenomenon, and that's been really unfortunate for a lot of headache sufferers, that they've had that implication that the headache is purely due to psychological factors, which is where the term stress headache probably came from, and tension headache, psychogenic headache, all these things that imply that there are only psychological factors involved. And then when the updating of the name, when it became tension type headache, the intention, I assume, I can't find anything to back this up, so this is an assumption on my part, but I think the change of name was from tension headache to tension type headache to try and describe the sensation of the headache rather than implying that it was related to stress. So the sensation of tension or tightness of the head, of the scalp. The cause of tension type headaches, it's not fully understood, like a lot of conditions, like a lot of pain conditions. But similar to all conditions in the human body, every single one of them, it's a complex interplay between biological factors, psychological factors, and social factors too. So if you're thinking of it from a biopsychosocial point of view, there's always those three kind of elements involved. It was thought initially that the reason for tension type headaches was related to scalp muscle activity, scalp muscle tone, though through studying it, it was found that the muscle activity during a headache, during a tension type headache episode, wasn't any different to the muscle activity outside of a headache episode. So that theory seems to have been largely ruled out, although there's still a hangover from that. You'll find people will still blame tension type headache on scalp muscle tightness and doing things to help relax scalp muscles. Instead, the more recent research has shown that tension type headache is a result of an extra sensitive pain system, an extra sensitive pain protection system. So when the pain system becomes more pro-nociceptive, when it becomes more tipped in favour of things being interpreted as dangerous, then there's more chance that a normal input will be perceived as being dangerous, and therefore more chance of the sensation of pain being produced, in this case, tension type headache. And so this means that even non-threatening inputs that are not dangerous, that are not normally perceived as being dangerous, are interpreted differently by the central nervous system, the body in general, interpreted as being potentially threatening. And so there's a shift or an increase in chance of something being interpreted as threatening and felt as painful. And if you look at the inputs that can be potentially perceived as being threatening and factors, triggers to tension type headaches, it can be stress, it can be missing a meal, it can be not drinking enough water, it can be having a bad sleep, it can be postural stresses, it can be hormonal changes, it can be eye strain. So all these different factors can be part of the mix that is involved in changing the threshold of making it easier to produce a headache experience. And they can work individually or they can work in combination. Oftentimes it is a coming together of a number of different factors. One of the factors that can be involved is the input of the upper cervical spine, the upper neck, which can be a really potent influence on the system in headache production. What's interesting is that the neurological features of this type of headache, of tension type headache, the neurological features aren't that different to the neurological features of migraine. And that's why it can be hard to differentiate between migraine without aura and other kinds of headache, because there's a similarity in the presentation, in the way that they're triggered, in the experience as well. And the main neurological feature that is common across all these different kinds of headaches is the role of the trigeminocervical nucleus, or the trigeminocervical complex, which is an extension of the trigeminal nucleus that involves the upper cervical spine. And if it becomes more sensitized, it becomes more easily excited, and it's less fatigable. So it's just a bit more on, it's a bit more jazzed up, and a bit more likely to be involved in setting off a situation like a headache, like a migraine. The upper neck is a well-documented input to the trigeminocervical nucleus, and it means that it's got a role. It's got potentially a potent role in sensitizing or maintaining sensitivity of this nucleus. What this also means is that the upper neck can be used as a way of desensitizing the trigeminocervical nucleus because of its involvement too. And this is the basis of the What's in a Headache approach to helping people with headaches and migraines of different varieties. The medical diagnosis for tension type headaches is down to history taking. So symptoms, how the headaches behave, intensity, location, and how often, in order to classify them from either episodic or chronic. Scalp tenderness has been used as a physical sign for tension type headache, but scalp tenderness can be found in lots of different kinds of headaches and migraine conditions, so it's a pretty non-specific kind of sign. That used to be interpreted as a sign of muscle contraction, when in reality it's a sign of a system that's sensitized. Most of the time, extensive testing isn't required, but there may be bloods, there may be imaging done to rule out other pathologies, but there are no tests that will tell you whether you have tension type headache or differentiate from any other kind of headache. There are no imaging tests, there are no blood tests that will say, yes, you've got tension type headache. It all comes down to the history and the behaviour and the location. In the classification system that's used, the International Classification of Headache Disorders, which is up to its 3rd edition, there are particular subtleties between the definition of episodic and chronic tension type headache, but broadly speaking, the headaches that can last from 30 minutes to 7 days. They involve bilateral pressure or tightening sensation. They talk about them being mild to moderate intensity. I argue that there are people out there that definitely have moderate to severe intensity tension type headaches. They're not aggravated by physical activity, and they don't involve nausea or vomiting, photophobia or phonophobia. However, frequent tension type headache of the episodic variety can involve photo and phonophobia, and chronic tension type headache can involve nausea. Photophobia and phonophobia are signs of a processing system that is jazzed up, which can happen across lots of different headache and migraine varieties. The medical treatment for tension type headache is often directed at this thought of the problem being related to muscle tightness or muscle tone, it seems, from my experience. So there will be medication given, which might be simple analgesia, anti-inflammatories, a lot of over-the-counter medication, which needs to be monitored because, as I've talked about on other videos and written about in other articles, medication overuse is a really common problem, and using your medication more than a certain amount per month over a period of months really sets you up for the potential of experiencing this extra kind of headache, which really you want to avoid. So medication is one part of the medical approach. Another one might be addressing lifestyle factors. Chronic tension type headache sufferers might also be prescribed antidepressants or muscle relaxants, antidepressants particularly in low doses, like amitriptyline, aka NDEP. Non-medical treatments that are often talked about are massage, acupuncture, psychology, stress management, things that can certainly help, but then they can help with any headache presentation. It's not just about tension type headache. The kind of lifestyle advice that's often given is looking at sleep, healthy diet, exercising more often, sensible advice, and put together, that advice can help a lot of people, no doubt about it. But there's still a population of people where it doesn't, and that's because it isn't necessarily addressing the underlying cause of the tension type headache, which is that sensitization of the pain system. And just to underline how careful you need to be reading on the internet different websites about tension type headache, and you come across some fairly reputable places like the Mayo Clinic and Stanford, and on the Stanford website, I quoted this in the article. There's a comment, from an intuitive point of view, biofeedback should help. And it really surprises me that a place of that kind of standing would be talking about things from an intuitive point of view that's based on a theory that has been disproven, which is that it's related to muscle scalp tension. So, the treatment that you deserve should be based on current understanding, current research. So how do we help people with tension type headache? At Adelaide West Physio and Headache Clinic, we use an approach which is first line Watson headache approach to assess the role of the upper neck. Regardless of the headache or the migraine problem, we want to know whether there's an upper neck component because it is so frequently underestimated and missed. And we use all of this underpinned by a biopsychosocial approach. So understanding that this problem is not just existing in a neck or in a head, but it's a whole person. And the Watson headache approach is different to a lot of manual therapy approaches which look for things that are tight or tender or stiff. We're really looking for segments that are capable of recreating the person's headache pain. So we know that there's a definite link between the two, and particularly if there's a possibility of recreating and then resolving that headache pain with that sustained pressure, which is the key to relevancy with the upper neck. So our overarching goal is to determine if there is a credible contribution from the upper cervical spine in this person's headache problem. In this situation, a tension type headache problem, is there credible evidence for the upper neck being involved or not? It may not be. Not every headache or migraine problem has got a neck component, but we also know that there's a really potent, well-documented input from the upper neck into all the parts of the brain stem and the brain that are involved in headaches and migraine. And we always screen first for any signs of dangerous conditions, red flag conditions, anything that would make us think this person doesn't belong here in our clinic, they belong at their GP's or A&E. So we're looking for anything that's sinister. We rule that out first and foremost before we keep going. And then we're looking at what's the pattern of the headaches, how often are they happening, what's their behaviour, what area of the head, trying to establish some key signs or key symptoms that we can use to measure our effectiveness with what we're doing. And then we examine the upper neck, looking for those key signs that we know we tend to find when there's a neck component to a headache problem. And then if there's enough suggestion from that there's likely to be a cervical component to the problem, then we look for proof of concept. So we will treat what there is and look to see if we can create a change relatively quickly within a few sessions is the aim, to add some credibility to the idea that the neck's involved. So we want to prove to ourselves, we want to prove to the patient that this is making a difference. And the best way to prove that is by changing the behaviour of the pain, how often, how strong, how long it lasts, some of those kind of factors. And we don't limit ourselves to just looking at the upper cervical spine. All of those other factors, lifestyle factors, are worth considering and are worth talking further about and perhaps making some changes to as well, because we know, like most problems, there's pieces to the jigsaw. The neck contribution might be a big piece, or it might be one of many little pieces. So it's worthwhile exploring those other factors more deeply. So some of the lifestyle factors, we might talk about sleep, we might talk about exercise, which is a really important one, and specific exercises to help with what we're trying to achieve with the upper neck as well. And then part of what we do is talk about prevention strategies as well, making sure that people have got some tools in their tool belt, things that they can continue with to keep things going well and to keep themselves headache free, but also what to do if they start to feel things tighten up, if they start to feel the headaches become more frequent. What are the first things to do before they even pick up the phone? There should be some things that everyone can do on their own that doesn't require someone else to do it for them. And hopefully in at least a good percentage of cases, people can settle a problem down, sort a problem out themselves without needing to seek further help. But we're always here if needed. So I hope you can see that tension type headache is a bit more complicated than was once thought. It's once thought to just be a stress kind of situation or a psychological problem. It's not as simple as that. The underlying neurophysiology actually isn't that different. It's still based on the idea of an extra-sensitive trigeminocervical complex. The lower part of the brainstem is on edge, jazzed up, ready to go, more likely to interpret normal, non-dangerous inputs as being potentially threatening. And often it's a combination of factors coming together that create that. And there are obviously a lot of factors involved in these headaches, just like any headache problem or migraine problem. Our first priority is looking to see whether we can rule in or rule out a neck component. And we normally don't take too long to make that call, whether there's a neck component that needs to be addressed or not. Usually we can say within our first treatment session if we've got pretty strong suspicion about it, and then we're looking for proof of concept within a small number of sessions. And in addition to that, we talk about the other factors that can be involved in the resulting tension type headache problem and how to address each of those. Hopefully that helps. If you've got any questions, there'll be a link in the description. Send them through to me or put a comment to the video below. But I hope that gives you a little bit more insight and maybe a little bit more hope into tension type headache and the fact that there are more things that can be done than just medication. I think a lot of people get a little bit distraught when they've been on medication for a while and it's not being as effective as it used to be, and they're thinking, do I have to try something different? Do I have to move on to a new medication, a stronger medication? Well, there are other things that can be done as well that will hopefully allow you to avoid that. So, ciao for now.